hear us up here, or do we need a microphone? Oh, no, I'm loud enough, right? No. Well, thanks everyone for attending. This is a mandatory clinical competency. Back when I started in the accreditation and patient safety role 15 months ago now, I've learned a lot about Joint Commission and state requirements, and of course after a couple months I found out that our license is changing. So found different updates for service plans and home patient agreements, medication management, so I brought an idea up saying maybe we should do a competency on it since these changes are going to affect clinicians a lot, and kind of learn more about what service plans are, how do we fill them out, why do we need them, things like that. So we are going to make it fun. We don't have any skits or videos. We do have candy. So kind of throughout the presentation, I'll stop and ask questions every once in a while, so will Josh, and you guys we can't answer them right.
So we want to make this somewhat of an interactive event. So it's not just going to be us up here lecturing to you, because we understand this material is dry enough to begin with, so who really wants to be lectured to? So really we do invite your participation, and that's where the candy comes in, as a reward. So
There will be a quiz too after this with Marlene out, our PHS University expert. A couple people are filling in. So once the quiz is done, we have to upload the video. It'll all be on PHSU. Susan will send out a thank you for attending and a link to watch the video, which will show the slides and also the slides as well, and then the quiz. So anyways, let's get started. All right, so. All right. So, to start, we're getting rid of our class licensure. Does anyone know what type of licensure we currently hold with the state?
High class.
Oh, Class A. Oh, I don't know.
Who said
Who said
Class
that first? Perfect. So yes, currently we have a Class A licensure. Second question is, does anybody know what type of licensure we will be going to?
B.
good guess.
Good
Home
guess.
care.
No.
Complex.
Close.
Yes.
Starts with this. Judy. Comprehensive.
Comprehensive. Who'd say comprehensive?
Judy.
Give it to them.
Complex.
All right, so it's coming soon. So a little test your knowledge, third question already. I'm getting you guys involved right off the bat. Does anyone know what the 4 classes were for home care licensure? So we had
A,
a
B, and D.
A, B.
C and D?
Oh, you had A, B, C. There's one more.
Let's fail. I don't know.
Starts with what you just said.
F.
Yes. So we had A, B, C, and F, and like I said, we held the Class A licensure. Good job, Bruce. All right, so why are we making these changes? Back in 2013, the Minnesota legislator decided that we needed to get new rules and regulations for home care. The law will be fully implemented by July of 2015, at which time all providers must be licensed under the new law. So what it's doing is it's streamlining 4 licensures at A, B, C, and F into 2. Your first licensure, we liked this model, that's what they came up with, is your basic home care license, and that's going to be for your home health aides, your PCA services, and there's a lot of companies out there that do that, so a lot will fall in that one. Everyone else for home care is going to fall under the comprehensive home care, which would include us. So your basic doesn't have any nursing services or licensed services, but your comprehensive does. Another thing to know is if you have a comprehensive license and you decide to do any of the basic license, PHS isn't doing that, but in case we ever decide to do PCA's home health, we could do it. It falls, you don't have to get a comprehensive and a basic. Basic is covered under comprehensive. All right, so some key changes. The big one is going to be frequency of surveys. So question to you guys is, does anyone know when PHS had the last survey? What year?
Survey.
State survey.
State
So this is a state licensure survey.
2002.
2 years.
If somebody's close, no one said it Close to
2011.
2005 's close.
2006.
Yep, 2006, okay. So it's been a little while, so with these changes, they are gonna change so that surveys are once every 3 years. Josh and I have a bet that neither one of us want to shake hands on, but we're pretty sure that the state's probably gonna be here in the next year or two. Definitely by 2016, because then they'll be up to date, but we'll probably be getting a survey soon. Surveyor, well,
Is it possible they would come sooner?
I
They
think
could call
so, yeah.
next month, yeah. They
Right.
could be here.
Right,
So they could be here, like we say with joint commission, they can show up at any day.
right.
And the point I think we're trying to make is that we are way overdue for a survey, so.
Right. So this next one for your surveyor training requirements, they're going from 4 surveyors to 22 surveyors. So they are increasing their surveyor. So if you think the whole state of Minnesota and only 4 surveyors, kind of makes sense why we haven't maybe had a survey for so long. They'll be hiring them in increments, so it's like a third are hired this year, a third of them will be hired next year, and then 2016 they'll have 22 surveyors. There'll be a new process for imposing fine. The change adds a new process for imposing fines based on the scope and severity of violations. So it gives the department a better scope of what they are, and then it helps us as home care providers understand a little bit more what they could do. The increase in fees, not totally surprised, but they are doing this to support staffing levels necessary to conduct timely inspections and enforce actions. Medication management clarification, I'll be going over that in a little bit. There'll be some updates and more definitions surrounding that. And then quality management plan. So it will require agencies to have a quality management plan. It's less prescriptive, and new laws say everyone needs to have one, but it only needs to be adapted to the company. So the company gets to decide how we do that. PHS already does this. Anyone know a couple examples of how we already meet QIC? Yep. Anybody else?
That's right.
Pigs. Medication error tracking. Perfect.
The only other comment I'd like to make just about frequency of surveys is up till now, as you heard Melanie mention, the Department of Health is only staffed with 4 surveyors. So they're really focused on new agencies as well as concerns and complaints that are brought to the department. So in a way, the fact that we haven't been surveyed in, 6, 7 years is almost a compliment. But as we've heard, they're upping their staff to 22. And definitely that will be part of the ongoing process for licensure renewal moving forward, so.
And if you think of it, the 22 surveyors only have to learn 2 licenses now versus the 4 that were before, and all the different things surrounding that. So some key dates. January 1st of this year is when new providers had to start applying. Any new providers that are signing up for home care or opening a business had to apply for either the basic or the comprehensive licensure. So July 1st was another key date. This is when all providers licensed by the Minnesota Department of Health prior to January 1st of 2014 will transition to the new set of requirements, and this will end June 30th, 2015. So does anyone know when our license is due? I won't maybe ask the exact date, but anyone know what month our license is due?
It's not fair, I knew that from this morning.
August.
Close.
September.
September 23rd, 2014, we'll go from Class A to comprehensive. And then June 30th, 2016, a survey of home care providers will be completed on all home care companies at least once every 3 years. All right. So a little bit, kind of go through this kind of quick, but the on-site survey process, there is an M-Files document that talks about how to respond to a state of Minnesota survey, comprehensive licensure. So mainly, a lot of it is pretty similar to Joint Commission. So they're gonna come in, we'll have an entrance conference with them and kind of come up with a game plan, how long they're gonna be here, what we're gonna do. Just a lot of communication with different managers, people here in the office. We'll get a tour of our office, and then we select the different home care clients to go out to. Mainly, we usually do clinical respiratory, IV, or a home care nursing home. Just like Joint Commission, if we call the home, of the family that the clinician's going out that we think would be a good fit. If they say no, they have that right. They don't have to go to that home, so they can say no. Then mainly the next two are just kind of information gathering interviews that'll be done here in the office. They'll talk to different employees, ask questions, same thing in the home, talk to the caregivers, talk to the patient if the patient is old enough they can understand. And then at the end, they'll do an exit conference where it's documented that we have had a conference, go over a little bit of what is found, so. All right, test your knowledge.
Now,
Yes.
is that whole process like over a week or how long
How long
from
was our last?
entrance to exit?
Well, neither Melanie and I were here for the last survey, so I don't.
I can say that generally speaking, it's not like a 3-day survey, it's not like joint commission, but understanding there was 1 or 2 surveyors for thousands of agencies, so they were here for perhaps an hour or 2.
And last time we had a much smaller patient population. We didn't have HCN. We certainly had ID at that time. But so depending on what they're finding, they could be here. I don't know if they'd come for another day. We don't know yet. But it would be very similar, like Melanie said, to Joint Commission, where they would actually go out to a patient's home, ask the clinicians in the home, ask office staff questions, and just kind of follow the process through.
Since they started this, they called here looking for information. They were looking into another nursing agency, so they called us and followed up. So I think maybe it wraps up, but they're still doing background work for some amount of time. But she needed it quickly, like she needed the responses very quickly.
So in other words, you mean the other agency that they were surveying needed information?
No, they were surveying and had gone to a patient home. That patient's home used us, so they were looking for our latest information on doctor's orders for feeding. Because what they were seeing wasn't jiving, so they were looking for our input too. So we may see more of that
Right,
too.
sure. Because we do partner with so many other agencies out there. We take care of these kids.
All right, so what is your role in keeping us, making sure we do well on the surveys? If anyone sat through any of our regulatory orientation or has done a tracer with me, you guys are already ahead of the game. It's a lot, just like Joint Commission, so ask questions, admit mistakes, so quick question now too. If a mistake is made or an error and it causes patient harm or has the potential, what usually happens in those cases? What do we usually do? PY. And what does that usually initiate then? RCA, a sentinel event. So then are all RCAs sentinel events? Good, right. I've done a couple RCAs where there's a little trend where there's misshipments of formula, so we performed an RCA on that, but that wasn't necessarily a sentinel event. But all sentinel events are gonna require an RCA to be complete as well. Policies and procedures, work instructions, if they don't work, say so. How often do we, or supervisors, leads, managers, review work instructions and policies and procedures?
3 years. 2 years.
Yes, 2, some are annually based on what Joint Commission says. So obviously that's a long time in between reviewing policies. And we know at PHS how much we like to change things up here. So if things don't flow right in there, let the document owner know. And know how to find the answers. Where's the biggest place you can find answers? And files, perfect. And then answer any questions the best way you can. What I like to state with all, especially like new nurses that I do orientation with, is it's completely okay to say I don't know to a question, but then following it up with, but I know where to find it. I would go on to M-Files and search here, or I would ask a coworker, I'd go to my manager, I'd ask a family member. So just always knowing where you can find the answer, but there's so many policies and procedures, there's no way you can know them all. So with that, Josh is gonna step in, I believe now, and kind of go over setting up patients and the documents and paperwork that we need with that.
Perfect, okay. So we're kind of taking this so you don't have to listen to me go on and on and on for the full hour, or Melanie go on and on for the full hour. So we're switching it up a little bit. Just as important as knowing how to respond to these surveys and why the surveys are taking place are some of the requirements that we have to meet when it comes to the state of Minnesota. One of the very important ones is our Minnesota Bill of Rights. We have to provide a Minnesota Home Care Bill of Rights to all of our patients. But question for you. Does it only apply to home care patients? True or false? Exactly. Good answer. So the Minnesota Home Care Bill of Rights actually applies to all healthcare providers, not just home care. So hospitals, ambulatory day surgery centers, assisted living, nursing homes, hospice. Every patient who receives services from one of those providers is obligated to receive a Bill of Rights. So how do we here at PHS provide our patients their Bill of Rights? Care and service booklet. In case anybody has no idea what a care and service booklet is, I brought one just in case. Where in the care and service booklet are the Bill of Rights located? That's not quite as quick.
It's on the back.
In the back, yep. So the back section of the home care bill of the care and service booklets, there are 2 pages with the Bill of Rights.
And just to clarify, if they get a 3-ring binder, so if they get materials that are in a 3-ring binder, it's under the care insurance tab. They wouldn't get that booklet, they would just get a binder that has a tab with that information.
And all of this information then would be in that care and service
Yes.
section of
Yep.
that binder. Good point of clarification. All right, so how many Bill of Rights are there? How many rights, what's the number I'm looking for?
25.
Close.
20.
Somewhere between 20 and 25.
21.
24.
Can I get a 22?
She wouldn't shout it out, she said it.
Good job. Good job. So there are actually 22 rights. These are rights that are identified by the state legislature. So PHS didn't come up with these rights. Department of Health did not come up with these rights. They're actually written into statute, written into law. For those law geeks out there, I don't see Sammy or Bill, but it's statute 144A.44 is the actual statute that identifies all the Minnesota Home Care Bill of Rights. These are rights, or these rights are really meant to help protect our patients. So they're meant for the benefit of our patients, to protect their services that they're receiving. And I mentioned this already, it applies to all providers. A provider cannot request or require that a patient surrender these rights as a condition to receiving services. So they are guaranteed rights. All right, we're going to go through a couple of the more important rights because they are very important. And as Melanie will cover a little bit later, it's important that we cover this during orientation, according to the Department of Health. So I want to talk about some of the more important rights. So our patients have a right to be involved with setting up their care plan. They have a right to know what services they're going to be receiving, and they have a right to participate in their care plan. So question for you guys, how do we do that here at PHS? How do we get them to be involved in their care plan when we initially set a patient up? Is there a document we cover with them specifically? Our service agreement, exactly. Our service agreement is our informed consent. That's the document where we sit down with the family, the caregiver, the patient, and we cover the services that we're going to be providing, how much we charge for that service, the frequency of our visits, what to do in an emergency, the contingency plan, advanced directive information. That's that process. That's how we get the family to be involved in providing and setting up their care plan. Patients, as you all know, have a right to refuse treatment or services. That's their right. They certainly can do that. If they do, obviously, we're going to be having a conversation with the provider. We want the provider to know. And then we also, in some instances, have the AMA letter. So we would have them complete and sign an AMA letter in some of those instances. And this is covered again in the service agreement, but they have a right to know prior to receiving services if there are any limits to the services that we can provide. For example, we don't provide PCA services. So that would be information we would share with the family if they wanted to know that. They have a right, families have a right to choose their provider. So the hospital doesn't say you have to go with PHS. I don't know why they wouldn't want to, but they don't have to go with PHS. Families have a right to choose who will provide their care. Of course, as you've heard me say before with HIPAA, families and patients have a right to their medical records. This is a big one at PHS. They have a right to be served by people, by staff who are adequately trained. As you all know, we have an excellent education department. We go through a lot of training here at PHS. Our HCN, our field staff, they go through is it a 7 day or is it or 5 days or is it 7 days of training now? 5. A whole week.
5 to 7.
5 to 7.
Yeah. For new grads, it's often 7 or more.
That's a lot of time we spend on our field staff. But we do that because it's the right thing to do. We want to make sure they are comfortable out in the home and taking care of that patient. And it's one of the rights. Our patients have a right to have properly trained staff providing care.
Just a point to really explain that training process. They also have preceptors that participate in patient-specific training as well as buddy shifts. So there's even more training than the 5 classroom training days that we have here.
Thank you. Yeah, absolutely. It doesn't just end here in the office. It continues out in the field. And same with our RT staff. There is at least a 6-month ramping up process for new respiratory therapists to come on. So we have a very vigorous learning block process and orientation process for all clinical services. Obviously, this next one's a no-brainer, but it's sad that we have to actually have it spelled out in a Bill of Rights. But patients have a right to be treated with courtesy and respect. Remember, we're going out into the patient's home, we're going into their environment. They're not coming to PHS to receive care. So we have to keep that in mind when we're out in the home. That's their environment, that's their home, that's their property. Obviously, patients have a right to be free from physical, verbal abuse, neglect, financial exploitation. There are a couple of different Minnesota acts that specifically address these issues. Patients have a right to at least a 10-day notice if we choose to terminate a case. It's pretty rare that we choose to terminate cases here at PHS. We work very, very diligently with families to ensure that we have a safe care plan out in the home. But if for whatever reason we do need to terminate that case, patients have a right to a 10-day notice. There are a couple of footnotes to that. There are a couple of exceptions where that 10-day notice is exempted. But those are very unique situations and circumstances.
Is that 10 calendar days or 10 work days?
I believe that would be 10 calendar days. Well, that's a good point. There is. It's not actually stipulated in the right, so we could clarify that if we ever needed to. Patients have a right to complain. They certainly have a right to complain if they feel like the service or their care is subpar, or their property was not treated with respect and they were not treated with respect. And we'll get a little bit more into the complaint process in a few minutes here.
I have a question.
Yeah.
Obviously, they retain the rights, but how do those rights change in like a CPS case?
In child protection case? Well, so if child protections is investigating, we as a provider have to cooperate with CPS. We want to cooperate and provide them information. But the patient still has those rights until a determination has been made. So if it's a custody case and they temporarily lose custody or custody is placed with foster care or in the court system, then those rights would transfer to that person who is providing care for that patient.
So the rights remain with whoever is the guardian of the child at the time?
Correct.
Okay.
Good question. All right, another test your knowledge. We're going to move on to the service agreements, which is another very important document. What information is on the service agreement? I'm looking for 5 pieces of information.
Welfare directive?
Welfare directive,
Emergency contact, service provided.
service provided,
Type of visit?
I would say that's kind of service provided. Frequency.
They will receive their bill of rights.
Fee schedule. The information at the bottom, did they receive the bill of rights? Yep, exactly. Perfect, exactly.
Crystal.
All right, so one of the changes, in addition to the ones Melanie's talked about now, the bill of rights is pretty much static. That has not changed. However, the service agreement is no longer going to be called the service agreement. It is now going to be called the service plan. So it's a point of clarification in the nomenclature. For those of you who worked with customer service and PAs, the state DHS, which is the Department of Health and Human Services, sets up service agreements with many of our patients. Many of our home care nursing patients have service agreements where the state says they'll cover this many hours of nursing. That's a service agreement. I think that was also getting confused with Department of Health service agreement, which is why they're changing to service plan. So it's still the service agreement that we're very familiar with. That has not changed. The title has changed. So all providers are still required to enter into a service plan with the patient. As I mentioned earlier, it serves our informed consent. It really is an opportunity for you guys as clinicians to sit down and discuss the care that we're going to provide for the family. How often we're going to do the visits, what types of visits we're going to provide, as I mentioned earlier. It must be obtained for all patients receiving clinical service. So not just those services that we're billing for. It's all patients who we provide services, clinical service for. So that really, I believe it impacts everybody here at PHS, or everybody in this room. A new piece on the service plan, MDH did stipulate that we have to have a statement identifying the services that PHS can provide under a comprehensive licensure. So this is what the service plan looks like, in case anybody here has been living under a rock and has never seen one of these. We did add some verbiage down here that stipulates PHS is a licensed Minnesota comprehensive home care provider and provides the above services. So that's, I mentioned that statement earlier. Otherwise, everything else on the front of this form is pretty much the same. The back of the form, we made a couple of tweaks too. So the service plan has to also identify how frequently we're assessing the patient. So we've added some of that verbiage in the back. And also that staff are how we monitor supervise clinical staff. So we identify that at the bottom as well. As you know, we annually review for competencies. This is one of those competencies. We do ride-alongs. There's plenty of additional CEU learning opportunities that we provide. So that's all part of the way that we continue to train. All right, another test your knowledge. What do you do when you go out to the home to set up a patient and let's say the legal guardian is not there? How do you obtain a service agreement at that point? What can you do?
Leave a copy there for them to sign.
Leave a copy there? Exactly, you can do that. Now keep in mind, when we're filling out the service agreement, we really have to have a conversation with them. So if you leave a copy, would you call them on the phone? What additional steps would you make? Call them on the phone to go through some service plan? That's a completely acceptable answer. Another one is to mail the service agreement and then call them on the phone, or fax the service agreement. I don't believe it happens very often, but I know back when I was out in the field, there were a couple times when the legal guardian was not available to sign the service agreement. So
I know I had to do it with a child protection case where the county was the legal guardian, so I had to fax it over to them to sign, and then they just faxed it right back. I made sure to fax both sides though, so you'll have to make copies so they have all the information.
And that's a key piece too. Keep in mind that the service agreement and the home patient agreement have to be signed by the legal guardian. So If it is a case where the patient's in foster care, oftentimes it's the county who has legal rights for that patient.
Do we have a process in place now that gets that new form signed in customer service with, like, CPS cases? Because I think that's a good question that she asked earlier on. You know, who's really responsible for getting that new service agreement when these things change, especially when there are multiple services involved?
Yeah, there is a process in customer service to catch when some of those occur. I believe it's tied into the insight process.
Okay.
So if custody actually changes, and then we have to obtain a new home patient agreement and service agreement. But we really have to continue to communicate across departments. So if you guys identify that something has changed with custody with one of your patients, make sure that that's getting communicated, and that we're updating our medical records, of course, to reflect that change. And that's when customer service would catch that we need to update the documents.
And that would be the same for when they actually, like, they're fostering a child and then they become their custodial, so they get that signed agreement from the judge. So then we'd actually then need a new agreement, even though their address didn't change, because their custody now changed from county
Correct.
or wherever to them.
Yep.
Okay.
Correct. There is a policy on service agreements out there. It's on files, policy number 376. So if you have additional questions about obtaining service agreement, I would point you to that as a reference. I was just going to say, as a matter of practice, when we need to have a service agreement obtained within 7 days of starting the case. So within that first 7 days is when we assign service agreement back.
And we currently have experts in informed consent now. Our infusion nursing team has all been tested for our upcoming CLABC study, and so they've received extensive training in informed consent. So any questions, they'll share their wisdom.
I see a lot of smiles back there. We'll just move on. And it is extensive training. All right, moving on to healthcare directives. So talking a little bit about healthcare directives. A lot of this has not necessarily changed either, but I wanted to just take a minute and talk to you folks about what to do if a patient has a healthcare directive, or let's say they don't have a healthcare directive and you're out in the home and something happens, God forbid something happens. And let's say the parent wants to change their healthcare directives or wants you to stop administering whatever treatment or care you're administering. That's a really uncomfortable position. What do you do as clinicians in that instance? Well, the state has some really clear guidelines on that. If you're requested to discontinue life-sustaining treatment, do not stop what you were doing. Do not take any action to discontinue that treatment. We have to do some investigation first. So what you do need to do, though, is promptly notify your manager, your supervisor, your nursing supervisor, case manager. And then what our obligation here in the office is to do is to inform the parent or legal guardian that the request will be made to the physician. We have to have a physician's order to change treatment. Then we would inform the physician, and then we would work with the physician and the legal guardian to make sure that the patient's Healthcare Directive Act is met and that we follow their requirements or their requests, their wishes. All right. I don't know that that has ever come up before, but certainly the potential is out there.
Can you explain a little bit about how the healthcare directive fits with a child under 18? I've never been clear on that.
Yeah, healthcare directives are really geared towards adults.
Okay.
So absolutely, it really, there's kind of a disconnect there.
Okay.
So it would be the legal guardian who would identify what the care steps would be in these cases, the treatment steps. Obviously, again, we need to work really closely with the physician to see if that's appropriate and to make the best determination moving forward.
That's different than like an emergent situation though, like say you were providing CPR and they were full code and the parent asks you to stop.
Right.
That verbal is still, like, you're not gonna be like, oh, I have to call my supervisor, like.
Right. In that situation, you have to continue CPR. So in that situation, you're not stopping
You don't,
your
so
treatment.
you have to go with what the health, so that the verbal is no longer okay to change healthcare directive within.
Maybe I misunderstood the scenario, so.
So like,
you get it?
the child is a full code, like they
Uh-huh.
want, the parents want everything to be done, so you're
Yeah.
providing CPR, and then the parent requests for you to stop and
Mhm.
say, you know what, I don't want this anymore.
You have to
can't stop
follow with,
anymore?
you have to follow with the full code.
Okay.
There's a process to go through advanced directives, or a healthcare directive if they don't want to be a full code, if they don't want compressions. There's a specific document, a specific process that has to be followed, so.
And then when I was trained before, so if they are like a DNR,
uh-huh.
and then the child starts coding and parents want you to start compressions, in the past, a verbal was okay to start like two compressions, can we still do that?
I believe so, I'd have to double check that, but
Oh,
yeah.
yeah,
the-
Yes,
Parents can
yes,
change.
yes.
Well,
Parents
The
can-
parents can change it at any point in time.
Does,
Anytime.
well, okay, so can we clarify that, because full code usually means they
Do
don't have a
everything.
directive, so we usually just classify them as full code, so if you're doing compressions in an emergency situation, and the parents ask you to stop, you can't. I mean, we don't have any kind of documentation, well, we do have our service agreement saying they're full code, but it's not like written anywhere that they're full code.
The only,
It
the only,
seems weird that we would continue CPR if a family's requesting.
Can we
Yeah.
research that a little
Yeah.
before we answer that finally? I'm not sure
Right.
of the likelihood of that scenario,
Right.
and,
Right.
but I
Right.
would like to follow up on that
Yep.
for the advice. But if a parent, if there's a DNR and the parent says, I want you to do a code, you're gonna do the code.
Right.
yeah. Good questions.
Yeah.
All right, concerns or complaints? All healthcare providers have to identify a process for patients, their legal guardians, to file a complaint or a concern with the healthcare provider. We have to have a written policy identifying how we receive those complaints, how we investigate the complaints, how we provide for reporting, and then how we resolve the complaints. So again, going back to my favorite document, the Caring Service Booklet, there is a page in here that identifies how to file a complaint. So our patients and legal guardians receive information on reporting concerns or complaints. Hopefully everybody's seen this before. It's very specific. It goes through the process. Mark Hammond is listed on this document as a contact individual. And then in addition to that, we also have a couple of external contacts, one being the Joint Commission, another being the Office of the Minnesota Ombudsman for long-term care, and then there's an Office of Health Facility Complaints. So patients have external resources to complain if, or bring their concerns to if they feel that PHS has not sufficiently addressed their concerns or complaints. As you well know, that's something we take very seriously here at PHS. So to the best of my knowledge, no concerns have had to be reported externally. We do address some immediately internally. There also has to be an explicit statement on this page that states that providers will not discriminate or retaliate against any parent or guardian who raises a concern or complaint. We want them to know that they are free to do that without fear of any retaliation. All right. Now, just as important as our service agreement and Bill of Rights, let's talk a little bit about assessments. This is basic information. A lot has not changed with the assessments. We still have to provide an initial assessment when we set up a patient. It must be completed within 5 days after initiating service. And it can be completed by a couple of different individuals. It can be completed by a registered nurse, or if it's a service that we're providing, another service that we're providing, it has to be completed by the appropriate individual. So for instance, and healthcare professional, I should say. So for instance, respiratory, we would need a respiratory clinician to complete that initial assessment. Or if we're providing dietitian services, we have to have a dietitian complete that initial assessment. So the appropriate service. And then in addition, we have, of course, ongoing assessments and monitoring for all of our patients. This is really as needed. So if the patient's condition was to change and we would need to do a updated reassessment, that would be appropriate. If the patient's condition doesn't change, we can wait at least 90 days before we do a follow-up assessment. So there is a 3-month window there. And these assessments can be done either via home visit or via phone, or in some cases, maybe even through videoing, telecommunications. So there are different methods of completing these home visits, or these reassessments, I should say, excuse me. All right, with that said, I'm gonna let Melanie finish this up, talking about medication management, which is just as important as our assessments. In fact, it's part of our assessments. So.
I do want to kind of put it out there that we're still kind of reviewing the medication management process. Josh and Cammy and I are looking at wording, so we might not be able to answer all of your questions if you have any, but we'll definitely write it down and get back to them. But okay, so medication management, what does this mean and what needs to be done? I always used to kind of think med management is administering drugs, but it's a lot more. So it's performing medication setup. We'll talk about that a little bit more in a couple slides. That's mainly for our home care nurses, do a lot of medication setup in the home. So a few things kind of changed, nothing too big. We'll go over that in a little bit. Administering medications is part of the management, storing and securing medications, documenting medication activities, coordinating refills. There's just a lot that's involved under this category. So, requirements of home care providers: a nurse or an authorized prescriber, so an RT, dietitian, needs to conduct the assessment to determine what services will be provided, if there will be any provided. This one has to be done face-to-face. So our assessments, some of our assessments can be done over the phone. This one needs to be done face-to-face when we're setting up services for medication management. And we need to review all the medications. That's all the same still. We're looking at side effects, allergies, actions, what needs to be done to address any issues with it. Oops. Can you go back one, Susan? I was gonna do that. And then identify interventions to prevent diversion by clients or others who have access to medications. Diversion is any theft or misuse of medications, and that, like I said, a lot of that is reviewed with our home care nursing. So everybody who has medications managed by PHS has to have an individualized medication management plan. We're thinking that that's probably going to go in the service plan, but we're looking to see how we're going to fit that in along with all of the other things that are in there. But part of what needs to be talked about in the plan is a statement describing the medication management services that will be provided, a description of storage of medications based on the client's needs and preferences, any risks of diversion and consistent with the manufacturer recommendations. Identification or documentation of specific client instructions relating to the administration of medications. Identifications of persons responsible for monitoring and ensuring medication refills are ordered in a timely fashion, and who's going to do the medication refills and call those in. Tasks delegated to any unlicensed personnel. We don't have that going on here. So, and then any procedures for staff to notify a case manager or supervisor if any problems arise with the services. And then any client-specific requirements. All right, so we'll talk a little bit about medication setup. Like I said, it's done mostly through our home care nursing, and this is where a lot of times what you see is the night nurses will set up medications for the day nurses to give throughout their shift because they're really busy going to school, going to appointments, going to be gone all day. The state, a lot of it's still the same, but they're saying that we need to make sure that when we are doing medication setup, we have to document the date, the name of the medication, the dose, the time to be administered, the route, and then the name of the person completing the setup. So kind of look like a label similar to this. So question, it's 50-50 shot. Does all of those need to be in one spot, like on the label? That's what I thought initially, but it's actually false. There really isn't. When you read it, it just says there needs to be documentation. So how home care nursing currently does it is a lot of that is on the label, but the name of the person isn't, but there's a treatment record in Insight where they document that that's done with the date and time. So we do currently, as far as we can see, we don't have to change any of that, but there's just a few requirements. Luckily, we're already doing it.
Mel, so
Yes.
the documentation is just the label on the syringe, and then they rip that off once they are done administering, and that's okay?
Mhm.
It's still considered documented?
Yep.
Okay.
The final documentation though would be in the MAR, right?
Right.
They
They
administer.
Yeah,
have to
it was
administer it, and
administered
the
and
dose
by
is all in
whom.
there, yep, but then
Yes.
it also has the tar,
The
shows
tar
who
that says
sets it
I
up.
set it up, yep.
Yep, and I reviewed some tars, and they all had it for the homes that I know for sure did it.
To the best of my knowledge, the nurse's time and date, or date and initial, every
Initial.
single med that they put the sticker on.
Even on the label too, if there
Yeah.
wasn't, even if there's not a
They-
spot
Every
that
home-
says it?
Yeah, every
They
home
just
that I was
write it
in,
in the white space.
we were initialing and dating every single.
And time.
and
So we're going
well, I
above and
went
beyond,
to-
so,
Yeah.
perfect, awesome. Okay, so a few other things that we're changing. Prescriptions now need to be renewed every 12 months or more frequently if indicated by the assessment. I think there were some cases where it used to be every 3 months. That's been pushed out to every 12 months. So some information on prescribed and non-prescribed medications. The way the wording's looking in the law is that the home care company can make the decision of what needs a prescription versus what not. I think a lot of us know that currently home care nursing, I think IV, they need to have prescriptions for everything, especially to administer. So if a patient needs butt paste, they need to call and get an order for it, or Mylicon drops, just things that are sold under the counter that people give to their kids all the time. Home care nurses had to get orders for that. What it's looking like now is we could potentially have it in our documentation of med management that those over the counter we could administer. We're still looking at Joint Commission and looking at the Minnesota Board of Nursing to see if they're okay with it, but maybe good news, potentially good news, yep.
Currently, we do obtain a general order for over-the-counter
Yeah.
non-medicated
Mhm.
topicals, at least for
Yeah.
our home care. But if there's any medication in them, we do get specific orders for those. But
Right.
otherwise, baby lotion and powder.
Yeah, so I would continue to do that.
Yeah.
Potentially, there might be a chance we don't have
Don't
to,
have
but
to.
we're not 100, I can't say for 100% certainty that that's what it is. Same with medications that are over the counter, dietary supplements, things like that, and prescriptions. The state's saying that it has to stay in the same container that it was brought out to the home until you do the setup or until you're ready to administer. Prescriptions, so verbal prescription orders from an authorized prescriber must be received by a nurse or pharmacist. We're currently doing that. Same with verbal orders. They must be, then verbal prescription orders, not only do we need to receive in here, but the nurses in the home need to know about it. And just documentation of anyone, here. So same with the written or electronic prescriptions, we need to make sure we have something signed on file that we have in order. A lot of these last ones we're already doing, so it's just kind of an overview. Obviously, the records are gonna be confidential. And then we need to have a document, some kind of policy that talks about loss or spillage of controlled substances. So we must implement procedures for loss or spillage of all controlled substances. They must require us to investigate any known loss or unaccounted for medications and take appropriate actions. So if something like that were to happen in the home, how would we document that?
Like right now,
Yeah, like,
no, there's progress notes.
there's progress notes, and then
That's
us.
documented on the narcotic sheet.
Yep, so let's say the narcotic sheet is off 10 mils from when you were there last, and there was a nurse ahead of you, but it didn't say that they gave any. So the progress note is perfect, and then usually here in the office, we'll start the poke-yoke if it's looking like we can't account for that. Sometimes we can call that nurse or call the family and they'll know where it is, but definitely that's kind of considered like a medication error.
And before we move on, I want to draw your attention to the 12-month. Call me a dork, but I think that's really a pretty cool change. The previous rule stated that we had to obtain a new prescription every 3 months. So this is a big change. Doesn't necessarily impact HCN or maybe POT because of the assessments. So some of those patients we might determine that we need to reassess more frequently. But for our respiratory patients, for example, right now, we're cleaning an SMN for the respiratory visit every 3 months. That will be no longer. We can move that out to once a year. It's a big change, very excited about that, so.
How about POTs, Josh?
POTs would be, again, we'd have to consider the patient, the patients that we're looking at. So if we feel that they can go a year, then we can make policy changes if we need to.
Great.
How do you clarify like what medication management is? Because like obviously the HCM they're delivering it. We're just documenting as our RT, so
Right.
do we have to record if they tell us about loss or spillage or things like that?
No, I think that's a little bit more towards the HCN. I think for you guys, it's the cardiorespiratory medications that we'll continue to manage and follow, like you have been doing. And that,
And you see
Does that
manage,
change
just
with the way
yeah,
we're doing?
documenting, yep.
So is that different than this medication management? So this is for our comprehensive license. And when we are monitoring cardiorespiratory meds, is that through our license and or through joint commission?
It's
Well,
like there's a
absolutely
blurred
through our
It's-
license. I mean,
Yeah.
absolutely through our
Yeah.
license.
Yeah.
Joint Commission is an accrediting agency, so, you know, they have specific standards and recommendations, but definitely it's through our license. And what I'm not clear on is we also have infusion that does
Administer.
have medication, so how does this all apply across the board to all of the
Right.
clinical staff?
So, like we kind of said, every patient's gonna have an individualized plan. Like we said, we're looking to see if we can get it on the service agreement. That will kind of talk a little bit more about what that medication management entails and means. I think for home care nursing and IV, it's gonna be more than potentially respiratory, but,
Right.
so,
As respiratory clinicians, you're not administering, dispensing, you're not doing anything with the medication. The only thing that you're doing from a respiratory stance is you're reviewing their cardiopulmonary medications, which is a joint commission requirement. But from a state requirement, you're not administering medication. So there would be no requirements
Fall under the
from
medication
respiratory therapy.
management title.
Obviously, IV and HCN is very different. We are administering medications, so that's where the medication, individualized medication management plan comes into play.
And when do we plan to implement the renewal for prescriptions every 12 months versus every 3 months?
We'll have to talk about that, Judy. But we
I was
can,
thinking maybe this month.
well, no, we have to wait until our license renewal next month, so as of
Okay,
September
September.
23rd.
September
Yeah.
23rd.
Yeah.
Yes.
We're all over that.
Can we have a press release to our commission?
Right. All right, so the last part that I'm gonna talk really quick about is a little bit on orientation and training. So who needs to be orientated at PHS? Everyone, perfect. All employees. But the state does require that we cover certain topics. They really haven't changed. We have to do the regulatory training and home care bill of rights, and we already complete that. Go over any policies and procedures, especially the ones that are specific to your department in your area. We do a good job of training on emergencies, what we do here in the office. We've got a great emergency preparedness plan. There's 2 of them now. There should be 1 for what we do here in the office, as well as how we prepare our families out in the homes. So now they're only 4, those both are like 4 pages now instead of the long 9-page document it used to be. So vulnerable persons, client complaints, types of home care services, and obviously then orientation to the client that you're gonna be taking over and caring for. Okay, so what's changed a little bit is annual training. So the state is now saying that all clinicians, people that are providing services to our patients, need 8 hours of annual training for every 12 months of employment. For us here in-house, that's really easy to do. We have staff meetings that review the areas that they are saying that we need to cover. Basically, they're the same as what was in the first orientation. We're working on what we're gonna do for home care nursing right now. They come in every 12 months, right around their anniversary, and they get about a good half day at least. It's not quite 8 hours, So I know Barb and Josh and I are kind of looking at, and Sandy, how are we gonna make it so that we are ensured that they have it? Right now, Becca and Steve and Stacy just did a really great medication errors, how to reduce them, so that counts as one. And we'll look to see if maybe CEUs or other things that they could do so we can get those 8 hours.
It's a new online learning will help with that too.
Yeah, I think so, right, so we'll be checking on that. So, anyways, that's all we have. So, mainly what we really want to state to you guys, we just wanted to give you a little bit more insight as to why we do what we do. It's not stuff that we say, ooh, let's give them one more thing to do. We just ask that you continue doing what you're doing, and that's taking care of the patient. And let Joshua know if you have any concerns. So, any other questions?